Okay, so let's conclude this with some more details. Essentially, you want AI to advance disease modeling, but also disease predictions, and more especially in public health decision making, because even if you make predictions and they don't reach the right people at the right time, it may be useless. So decision making is going to depend on all that together. So here is an iterative approach to public health decision making. Conjectured use of AI to optimize the design and implementation of effective control measures during a hypothetical multi-country disease outbreak. We don't have to be very hypothetical about it, but this is about how to think about uh, the epidemic management, pandemic, essentially pandemic by the time it gets multi-country level, gets to multi-country level. Data collected from disease surveillance are processed and analyzed by an AI agent, potentially integrating with other AI models for parameter estimation, nowcasting and forecasting of epidemic trajectories, as well as reconstructing historical transmission events based on current observations. Reconstructing historical transmission events. So that's in the top row here. We'll come back. Before deployment of the AI model, it's trained using an outbreak simulator that simulates the spread of the infectious diseases and the effects of different control measures. So you take the particular location, with its demographics, socioeconomics, healthcare, etc., and then you make a transmission model before the deployment of the AI model. So you have some training, validation, etc. The model learns from these simulations by updating its model parameters according to the outcomes of the simulations and corresponding rewards. So we will look at that. Basically, that's the goal you have set for the model, like a cost function, let's say. Insights from the empirical data are used by the trainer model to inform and recommend the most effective control measures, with validation and feedback from human policymakers and stakeholders to fine-tune alignment between model objectives and societally beneficial criteria. Obvious, because you produce model output forecasts, you tell this policymakers what needs to happen, they do something and they say this is not working or this is working well, this can get better, and so on. So that feedback is very critical. This is followed by the execution of public health actions, for example, whether to implement recommended or alternative control measures or deploy further disease surveillance efforts made ultimately. I lost the track there by reading all. They have a nice sentence, but they put things in parentheses that if you read it, then the sentence becomes messy, which I should get better at reading anyway. This, so where was I? This is followed by the execution of public health actions, such as whether to implement recommended or alternative control measures or deploy further disease surveillance efforts. And these actions are made ultimately by human policymakers. The map shapefile was obtained from Africa Data Hub and so on. So specific data were used here. So parameter estimations such as incubation period, etc., follow after data collection, processing, and interpretation has happened, and then you combine it with mobility network, known hotspots or unknown. So you don't know, some places you have a blind spot because you have no data, and then you do some forecasting. So you have integration that's gone on, and you approach the current period, and then you go forward. So this is the historic simulations. They're called hindcasting in some, because you start and then you go forward in time, except that you are now doing it for the past. Hindcast as opposed to forecast. This is actually going forward in time, whereas here you are coming forward from historical periods. So historical reconstruction, phylogenetically inferred importation. So inferred location A, inferred location B. So it's some nodes and links that are working together. So real world outbreak happens, data gathering starts. There is a lot of background socio-demographic data already available. And then all this is feeding into an AI model. So policy action recommendations are done, validation and fine tuning is done with feedbacks, and then human policymakers are taking this and making decisions. And remember, scientists are doing all this, and policymakers are talking to the public and doing things, making decisions, so they are responsible for the outcome. So they have to be very careful, because often they face elections as well. So here they try to implement control measures of further disease surveillance efforts, and you can think of the masking mandate and all the controversies that went with it, especially in the US. They went after the NIH head, for suggesting quarantining, masks, and so on and so forth. So how people react to interventions is kind of a dangerous business sometimes, right? So the other part here is observations from simulated surveillance. So you have a way of using AI here as well. So you have outbreak simulator that happens beforehand, which feeds into the AI model, reinforcement learning kind of thing. Again, I'm being a little bit loose there technically. Update parameters according to rewards. So you have some metric that you are keeping track of that says you are going in the right direction. So that's the reward. Then you feed back to it, implement selected actions in simulators. So there's a constant feedback between what the policymakers are doing and how that is affecting the outbreak simulator. So when you go forward, you have a range that they have to deal with, but you want to keep this range as local and as narrow as possible to guide actions and policies, right? So that's why it's called an iterative approach, because you have arrows going back and forth. You're going this way and this way, you're going this way here and back and forth here, you're also going here to here and so on and so forth. So obviously can be done and needs a lot of data, a lot of people, a lot of teams to work together. Recommendations then for an infectious disease epidemiology. The risks of AI have been discussed at length, but their potential to transform science is unquestioned. When viewed through a broad lens, AI can be seen as a continuation of the rich legacy of mathematics, statistics, and computer science in the field of infectious disease epidemiology. Advances in AI have the potential to both complement existing approaches and to inspire entirely new epidemiological methods. Examples of potential breakthroughs in AI epidemiology include pre-training large and foundation models, zero-shot and few-shot learning approaches that require minimal data. You don't want to sit on your hands saying there's not enough data. You just start with data and start building and identify data gaps to say this is how we need to do it better. And of course, innovative new data architectures and computational environments to run and disseminate these models efficiently are needed, and they are part of the potential breakthroughs from AI to epidemiology. In part, these breakthroughs will be enabled by embedding of fundamental biological knowledge and constraints within AI models, which echoes development in the application of AI to other fields. However, the benefits of AI for public health will be critically dependent on the availability, accessibility, and representativeness of data and a firm ethical framework. This always comes up, so we must keep it in mind when we build tools. Even though more data have become available during the health emergencies, especially for COVID-19, routine surveillance data for infectious diseases often remains siloed and inaccessible to the broader community, prohibiting the use of these data for improved disease modeling. So this identified barriers and gaps that have to be filled, of course, right? However, the substantial volume of existing data means that advances aided by AI will probably be generated from existing openly available data sets. Once we know what can be done, people begin to participate, bring more data to the table, hopefully, and so on. More broadly, the quality standard for statistical models used in health domains should be higher than for other fields, especially for understanding of cause and effect is relevant to treatment and policy decisions, and when problems such as poor model calibration could cause considerable patient harm. So this is a business of actually saving lives as opposed to all the other noise we make about climate. Natural hazards kill less than about 1% of the total mortality across the world. More than 30% comes from cardiovascular diseases. So when we talk about infectious diseases, we are talking about saving lives. In a real sense. The development of benchmarks to evaluate new methods is therefore critical for building trust and for highlighting where AI might provide the greatest effect in the field. In part, this is why statistical models in medicine are guided not only by predictive accuracy but also value calibration, explainability, causality, and a rigorous theoretical basis. So black box AI model can be an issue when you want interpretability. We join the AI community in recommending that the fundamental theory underpinning current AI models is studied further. We advocate for robust data transparency and ethical sharing and a detailed study of a range of biases. Finally, we support the justifiable barriers. We support justifiable barriers of entry to including models into clinical practice and research into robustness, training, and evaluation of popular AI models. You cannot start running around willy-nilly with these models unless you can, justify their inclusion in clinical practice and policies that actually intervene with people's lives and livelihoods. Mechanistic models in infectious disease epidemiology continue to be developed independently of advances in AI. In this perspective, we have highlighted key areas in which AI could provide either incremental or potentially transformative improvements in modeling epidemic dynamics. However, evaluation of the true value added by AI approaches is difficult and should include often overlooked considerations such as the environmental costs associated with training complex AI models. So I have podcasts on how to make AI itself sustainable, because AI is percolating every aspect of life, from your watch to your car to your refrigerator and so on, and that requires a lot of energy. There have been recent examples in which simpler AI methods do not consistently outperform their mechanistic counterparts. Even when AI models do show substantial empirical improvements, translating these models into effective government policy requires considering many factors beyond mere data fit. Although the potential of AI models is evident, their ultimate value will depend on demonstrating a clear opportunity cost advantage over existing approaches, which has yet to be proven definitively, which means we are doing something, we are making decisions, we are communicating, we managed COVID somehow, and we have used certain methods, and now we are saying let's use more and more AI. Is there an opportunity cost associated with this? So give me a second, I'm close to finishing, but I have a phone call I must take, so I'm going to pause and come back. Okay, so let's go back here and wrap it up. Yeah, I had to take that call. As I said, I have a meeting. So AI models can be inserted everywhere, and we can convince ourselves that they are great. So we have to worry about the cost, opportunity cost advantage over existing methods, as well as make sure that they are actually worth ingesting into clinical practices and government policies and actions. Open access to and sharing of data analysis and results in a collaborative and transparent environment can greatly benefit the success of public health campaigns for infectious disease control. By contrast, the scale and cost of training foundation AI models is still increasing and is prohibitive for most. Although we hope that new ideas to mitigate this barrier will emerge, the current suite of AI models should be more transparent in their code, architecture, and data. The transparency issues always come up, data volume issues always come up, so we have to keep repeating them nonetheless. Likewise, the development of transparent and open access repositories of pathogen-specific data, for example, genomic sequences, environmental data such as temperature and land cover, and behavioral data such as human mobility patterns will remain central for training models and reducing data access inequalities. Finally, demonstrating the effectiveness of AI in improving policy decisions that benefit population health remains a notable challenge. For AI to be successful in that regard, the coming years must see growth in close collaborations between research, policy, and society. And in research, I'm a climate scientist working on environmental factors or climate change factors driving disease burdens like dengue, cholera, enteric fever, malaria, whatever. We have to work with epidemiologists and people who do genomics and other things. So research itself has to work together from multiple disciplines before we produce a model that we can talk about to policymakers and then to deal with society in terms of actually actions. Telling people what to do is a big onerous job. We often say, oh, I put a few instruments here, I'm going to save lives. But this is dangerous. If it's that simple, we wouldn't need disaster management agencies, right? Data is a very critical part of disaster management, but it's a long way to go from data to communication and disaster preparedness, prevention, recovery, etc. Because when the big tsunami hit in 2004, I think there was a tsunami warning issued, but in countries like India, nobody knew who was going to accept this warning and do something with it. Tens of thousands of people died even in India, far away from Aceh, where the earthquake happened. And you can imagine how far it is to go from a simple instrument to actually warning people and somebody being in the place to guide people to take action. So let's work with disaster management agencies, public health organizations, and so on to feed our data and build a system and not jump ahead to make claims about saving lives and so on. So let's keep that in mind. With that preaching, I will stop here. Okay.